very passionate about getting vision represented in multiple sclerosis and other demyelinating diseases for clinical trials, but also feel like this represents a great opportunity to use what is a very specific pathway, that is vision, and how we can measure it both using eye charts and new imaging techniques like optical coherence tomography. We think this will be a wonderful system for the future clinical trials to test efficacy of both standard therapies that we have for MS and demyelinating disease, but also our novel therapies that we've just been hearing about, and particularly those that involve neuroprotection, those that may allow us to preserve nerve cells and axons in the setting of these neurologic disorders. So today, I'm going to focus on some of the neuroimaging and also how do we measure vision clinically. And nowhere else in the central nervous system do we have this exquisite a structure-function correlation. We see with our eyes, our optic nerves, our visual pathways, and yet we're able to image using particularly, this is the newest generation OCT machine. This is the retina, by the way, and those layers that you learned about in biology class in the retina actually do exist. And this is the image to prove it. And this is the retinal nerve fiber layer, which carries all the nerve cables back from the retinal ganglion cells in the retina, the ones that receive the ultimate message of what we see, into the optic nerves. And so we're going to talk about that today. I'd like to acknowledge our collaborations with Johns Hopkins and with University of Texas Southwestern as well in all of these projects. And of course, I had to have a slide of my daughter, and our answer to the genetic quandary was to adopt our daughter, and we're very, very proud of her. And the influence of environment has been extreme, as you can see, because I love wonderful pictures, as you saw, imaging, everything's visual, right? And so does she. And so I think that we're going to have our first ever artist in our family. So we're pleased to have that. And so the visual pathways, we think about the optic nerves because many patients have had optic neuritis, right? You wake up and you have visual blurring, and maybe your vision gets better over a few weeks. But we've also shown that there's nerve cell and axon loss of those cables, loss of those nerve cells over time. And that can occur in the optic nerves even of patients with MS and other demyelinating diseases that don't have acute optic neuritis, and that's a humbling fact. So there is degeneration even in that context. And this is a study of patients at autopsy who died of other causes, say accidents, and these are the optic nerves of healthy people without MS and people with MS. And you can see that this is much, much thinner than this, and so there is axon loss, and so we do have a need for neuroprotective drugs both for MS and also specifically we can use this pathway to determine if we're doing well with our treatments or not. And so what is the advantages of testing our new techniques in clinical trials in addition to the studies that we're doing with patients who volunteer for our studies? Well, clinical trials are great because we have a very, what we call a homogeneous population. Patients who are chosen for a clinical trial tend to be more similar than they are different, and so that's a good thing when you're looking at new outcome measures. Patients tend to have active disease. To get into many clinical trials, you have to have had flare-ups or exacerbations recently. We're finding ways to do quality control for some of the vision testing that we do, and patients are followed for long-term beyond the clinical trials in many cases. And so someone just mentioned the MS functional composite. The way we really got into this business of studying vision in multiple sclerosis and other demyelinating diseases was that in the late 1990s, there was an international panel formed by the MS Society, and they were formed with the idea being that we needed more sensitive ways to measure how patients were doing in clinical trials because the EDSS scale that you've heard about is based on the neurological exam. It can be quite subjective and very weighted toward how you're doing ambulation-wise without as much attention to vision, cognition, and other aspects of how you're you're doing. And so the multiple sclerosis functional composite, or MSFC, was formed based on some old clinical trial data that they had. And they found that there were 3 dimensions or aspects of MS that they had measures for in these data sets that did well in the clinical trials. One was a timed 25-foot walk, and many of you probably do that when you go to your doctor's office. A 9-hole peg test, as we illustrate here, is helpful for arm function, and that's another timed test. So what you notice so far is these are objective measures where you're timed and doctor gets a number or the technician gets a number. Doesn't even have to be done by a physician or a nurse, just somebody well trained. The Paced Auditory Serial Addition Test, or PACEAT, is a attention or cognitive test where you add the numbers off of the CD-ROM or the tape, and my patients tell me they think it resembles the person at the drive-thru when you go to the restaurant. So it's very difficult to focus on that very bland voice that comes through, and so it's more a test of attention than anything else. But one thing we were struck by as a neuro-ophthalmology fellow then doing a master's degree in epidemiology was looking for a project to do, and I noticed, gee, there's no vision measure there, and so did my colleague, and hence we delved into the field of can we develop or find a better way to measure vision, a very, very important aspect of MS in clinical trials, and perhaps bring that to the clinic, bring that to how we evaluate our patients in the clinic. And so the MSFC has gained increasing use in clinical trials more recently, and I'm on a committee that's trying to figure out, based on some recent clinical trial data, what all of the MSFC data mean. But be that as it may, we are finding that it's a very, very sensitive measure that correlates pretty well with how patients are doing with MRI, and I'll also show you how vision might fit into that picture. How can we better measure vision? Well, back in the late 90s, there was data, as there is now, from the Optic Neuritis treatment trial, and that was a trial where they compared the effects of intravenous steroids versus oral prednisone, which we don't use for acute optic neuritis in many cases, or placebo. And their question was, can we improve upon visual outcome or not? And there were many interesting things that came out of that trial. But one of the things that was striking was that measures of low contrast vision, so eye charts that have gray letters on white rather than just your black and white eye chart, were more sensitive. And there was a chart called the Pelley-Robson chart that they used in that trial, but it was out of print. So it turned out that there was a standard way that they measure visual acuity, or black and white vision, in ophthalmology clinical trials, called the ETDRS chart, which actually comes from the early treatment diabetic retinopathy study. And that was the trial that actually showed that if you have diabetes, you don't have to go blind if you get laser treatment in many cases. And that was thought to be radical at first, but turned out to be a really great trial. So you notice this chart doesn't resemble your regular eye chart because it doesn't have the big E at the top. So it has 5 letters per line, proportional spacing between lines, and it's just a more fair test. You add up the number of letters, somebody gets correct. And so it has a gray on white cousin called the low contrast letter chart, and we thought we would give that a try as something that might, in clinical trials, help us get a grasp on what our patients were telling us, and that's that they saw fine on the black and white eye chart, but there was something not right about their vision, whether they had optic neuritis or not. And so we had an opportunity. We did some studies at Penn and collaboratively, but also in 2 clinical trials, one of which was the AFFIRM trial, which was natalizumab versus placebo, and had the opportunity to use the low contrast, that gray on white eye chart, to see as an exploratory measure, so not for the label, not really to say whether this drug helps vision or not, but does our eye chart work? And we were quite delighted to see that this eye chart, that simple chart that I just showed you that has the letters on each line and you just have the patient read it. In this case, with both eyes open, we wanted to minimize fatigue and see how our measure did, count how many letters somebody gets correct, and we were able to see that the patients in the active treatment group had a lower probability of getting worse with regard to their vision and staying worse for 3 months or more. And so our eye chart was able to show a treatment effect, which we thought was a very important functional aspect to vision. What about that black and white eye chart? Because we were using research methods here. Well, to make a long story short, it didn't do a thing. And so this is what our patients have told us. This is what you have told us all along. The black and white eye chart really doesn't capture the symptoms that I'm having with my vision. So we were delighted. As neuro-ophthalmologists, we want to be able to measure vision in trials, in the clinic, get at some of those subtle symptoms that you all tell us about. And we've done some studies at Penn and also in the clinical trials I just showed you that shows that low contrast acuity, if you add that visual component, it helps the MS functional composite capture disease. Our chart relates to quality of life. So if you take scores on this, what's a very standard quality of life measure, this is a very important aspect of how we measure any outcome, be it ambulation, vision, or any other dimension of MS. Does it translate into something that is important to you, to our patients? And the answer here, we think, is yes. This is a single time point. We administered this questionnaire, which is 25 questions about visual activities, such as driving, such as near activities, distance activities, color vision. And we found that if a patient loses 2 lines of gray on white vision, low contrast vision, then they lose about 7 points on this 0 to 100 scale, which is a very clinically significant, meaningful number to us. So we feel good about the fact that this is really a good clinical way to study vision. But does it have a grounding in reality? And that's where our ocular imaging techniques have come in. Okay, you read the gray and white eye chart. Does it mean anything with regard to what's happening with your disease in MS, in demyelinating disease? Is there axonal loss that goes along with that? So are we really capturing what's going on? And so there have been several studies. One study we did, we just looked at, do scores on the eye chart, gray and white eye chart, correlate with how much lesion burden you have in your visual pathways. Now, we don't just see with our optic nerves and our eyes. There's a whole part of the brain in the posterior part back here, this is the back of the head, called the visual cortex, and there's white matter and axons underneath that process what we see. And so we need that to see, in particular, things that are low contrast that really relate not just to seeing gray letters on white, but perceiving faces, for example, and driving, air-to-ground targets for pilots, very related to contrast vision. And so we found that in these posterior visual pathways, we call them, there are more lesions among patients who have trouble perceiving low contrast. So an important aspect of MS that we don't really think about. But importantly, we were able to use these new ocular imaging techniques called OCT to show that low contrast vision has a grounding in reality. It's related to how much nerve cell loss you have in the eyes. And so what this imaging does, this is how OCT works. This is the back of the eyeball. So here's the retina, here's the optic nerve coming out, and that's the cable that carries all of the nerve axons back to the brain to get your vision processed. And so here's a cross-section of the retina, and this innermost layer, this is the jelly in the eye called the vitreous. The innermost retina layer is nerve fiber layer. It's all axons. And the really neat thing about that is we think of MS and demyelinating disease as being primarily myelin, and there is no myelin in the retina. So these are central nervous system axons, just like you have in the brain, but there's no myelin. So this is an opportunity to see axons without the interference, if you will, of having to worry about, is it the myelin that's getting thin or is it the axon that's degenerating? And so what these scans do is they shine light, near-infrared light, into the back of the eye, take a picture. You don't even need to dilate your pupils if your pupils are 0.5 centimeter or more. And it's reproducible, and it takes about 15 seconds. So there's no MRI that takes that short a period of time. And we think that it'll be a good complement to MRI. It's certainly not going to replace it, but we've been pleased to see how well this ocular imaging result correlates with MRI. And so there are two ways we use to assess. One is OCT, Optical Coherence Tomography, and it uses something called interference patterns of near-infrared light. But be that as it may, what you see in the back of the eye is this is the optic nerve head. So when your eye doctor or your neurologist looks in the back of your eye, he or she sees the optic disc, optic nerve head. It's where your optic nerve meets your eyeball. And this scanner, basically when you look into the machine, goes around the optic nerve head 3 times fast, and it gives you a picture. And this orange here is your nerve fiber layer. And there's another method called GDX, or scanning laser polarimetry, and these all have very intimidating titles. But this is also a near-infrared light imaging technique, but what that tells you is something a little different. The OCT, we like to think of that as a method that does a scan, sort of like an MRI, tells you about anatomy. So the measurement you get in something called microns, so it's 1,000th of a millimeter, really tiny, tiny, thin layer. That's very similar to what you would get if you had an eye that unfortunately had to be removed and you looked at it under the microscope and you measured how thick that layer is, called histology. Very similar to that. So that's reality in terms of tissue. This other technique sort of tells us how healthy are the nerve cables, these things called microtubules inside that are the skeleton of the axon. And so really it's a very, very different method. And we've found so far that these two both are able to show us that there is loss of nerve cells and cables in eyes of patients with MS and other demyelinating diseases. So basically, that's very fortunate because you don't want to just have one technique or one method of imaging that shows that there's a difference between eyes of patients with MS and controls. You want to have two techniques to sort of validate each other. And we really went into these studies with the OCT to try to determine, could our low contrast acuity or our new vision chart show us something about how axon loss is occurring in the visual pathways. But one of the most interesting things that we found was that this is a graph that depicts how thick that layer is using the imaging. And in the green are our volunteers who are controls who do not have MS, and they're the thickest, not surprisingly. Eyes of patients who've had, or eyes that have had acute optic neuritis in the past are in the red, and those are the thinnest. So if you have acute optic neuritis, even if you get your vision back, there is loss of nerve cells over time. But here somewhere in the middle is a group of eyes where the patient says, I have not had acute optic neuritis, never any visual symptoms whatsoever, and yet those eyes aren't normal either. So we think that these techniques would be good even in patients who haven't had optic neuritis, perhaps to monitor disease both in clinical trials and eventually in the clinic. And there's something to be said for, this is the back of the eye, these fibers that we call the papillomacular bundle basically see your central vision, and so they tend to be more thinned in patients with optic neuritis and MS, and so we wonder why that is. Could it be that patients who have subtle visual loss or who have optic neuritis volunteer for our studies? That's one possibility, is that we tend to recruit, or there's a volunteer effect in that regard, or maybe these fibers that do central vision are more vulnerable somehow. And that's something we have to figure out over time, but that's something we found using these imaging techniques. Now you want to know, if I switch centers, I'm a Johns Hopkins patient and I come to Penn or I go to another place, if they use these imaging techniques for my eye, is it going to be reproducible? And so this is our collaboration, Penn, Hopkins, and University of Texas Southwestern. And one day we were just sitting and discussing how thick, on average, our patients' nerve fiber layers were using OCT. And we were surprised to see how similar these numbers are, 92, 90, and 93, essentially. And so really they're very, very reliable and reproducible across places. And some of the newer machines I'll show you can be done scans can be done by somebody who is not especially trained as an ophthalmic technician. So a student can be trained to do it, or even an attending physician can be trained to use this machine in their office, and we have one in neurology. We do not use it for clinical purposes yet. Why? Because I'm not exactly sure what to tell patients if things change over time. So for example, this patient volunteered for our vision study, and it's not a clinical trial, but it's sort of a natural history study where we're following patients with regard to their vision. His low contrast acuity has gone down in one of his eyes. This is number of lines he got correct, as has his nerve fiber layer thickness. So it's gone from normal, about 100 microns, down to about 92, where we see the average in our MS patients. And what we know so far about our big group of patients is that somehow patients get from having normal nerve fiber layer to having thinner nerve fiber layer in MS. The question is, how fast does that happen? In other words, if you have acute optic neuritis, you have pain on eye movement, visual loss, etc., we know that within 3 months you've pretty much lost as many of the axons or nerve cells as you're going to lose in that eye. But in MS, it can be a slower process, and so we're analyzing our group data now with special attention to the patients who are getting worse visually and what's happening with their nerve fiber layer. So we're not quite sure yet where OCT fits clinically, because could I tell you that it's variability or you're getting worse? That's a really, really tough call right now. There's another thing that we measure using OCT, and that's your macula. The macula, you've heard of macular degeneration. Well, that's the center of the retina where you use to read, do everything that's really important visually with regard to details. Well, that area has a lot of retinal ganglion cells. These are these little purple cells here. And so these aren't just the cables, but the actual nerve cells themselves. And one of the things we need to ask ourselves over time using these techniques is, what's the relationship between the nerve cell and the axon? Which dies first? Which is involved first in optic neuritis, for example? And we see that there's good correlations here between nerve cells, macula volume, we call it, and the axons, nerve fiber layer thickness. These aren't perfect correlations. Why? Because our machine, when it looks at the macula, it kind of looks at the whole retina, so it's not just nerve cells, but other layers, and some of the newer techniques are going to help us with that. But they do go hand in hand. And we can even look at the optic nerve head, especially in glaucoma. People use this to kind of see what's the cup to disc ratio. Your eye doctor may have talked to you a little bit about that at some point. Gee, your optic nerve looks like it might be cupped. You might have glaucoma. And I think the optic disc is not going to be something that we use with OCT regularly. Why? Because it's like noses. It's just so variable across people. You can have various shaped optic nerves, optic cups, etc. But what really is important, we think, is the thickness of this nerve fiber layer. So I think that's going to be where it's at. So many of the clinical trials that are ongoing now are including visual measures as a potential way to explore how drugs are doing, and we're exploring how well the outcome measures do. And so we have low contrast acuity and OCT, the ocular imaging, in several of the ongoing clinical trials, and I think that'll provide us with new data that will help us decide whether these are good measures, and perhaps they'll be used more primarily in the future to look at disease states and efficacy. And for example, the OCT is something that we want to do frequently. So it's really something that's simple. It just takes 15 seconds, but I think the more data we can get, the better. I think optic neuritis in particular, acute optic neuritis, will be a really important model for testing neuroprotection. Why? Because patients notice when they have acute optic neuritis, their vision's down, they have pain, they come to the doctor pretty quickly, and there is a definite sort of window of opportunity, we think, while the nerve cables are atrophying and nerve cells are being lost. There's probably a window in there which in the future, if you could give a drug that could protect those nerve cells, you could prevent a lot of the axon loss. Is that within a month? Is that within 3 months? Do you really have to get to the patient within a week? That's something that we need to figure out using this as a model. But I think it would be a very, very good way to test neuroprotective drugs that are coming around the corner. And then finally, some of the newer techniques. Well, as a patient with MS-driven myelin disease, you're probably saying, gosh, even though it's a 15-second scan, sometimes my eyes move a lot. That can be something that's troubling for patients. And so the speed of the machines are being increased. How well they resolve. I showed you that pretty picture in the first slide where we really can see all those layers of the retina that you learned about. And so we're able now to get 3D images. There are lots and lots of things that we can do. And these techniques are similar to ultrasound. So you see more sophisticated ultrasounds of fetuses and embryos these days, and that's where we're going really with this. And so we've gone from this to potentially this type of resolution. And Dr. Fujimoto is one of the developers of OCT techniques. And so I think we're going to be able to use this technique to determine different layers of the retina, our retinal ganglion cells, nerve cells being thinned in addition to the nerve cables. And so we look forward to using these techniques in the future in clinical trials and eventually in the clinic to help us determine how our patients are doing both visually and neurologically. The group at Hopkins has shown that if you look at nerve fiber layer thickness by OCT, it correlates well with brain atrophy on MRI. And so all this hangs together, and the way I look at it is it's a big puzzle, and it's our job to sort of sit down like my 6-year-old does. She's really good at puzzles, and she has this one now where there's big pieces and little pieces, and I don't know if it'll be done when I get home, but it's really a pleasure to work on this, and it's an honor to be here, and I appreciate all the input that you folks have and can take any questions. Thank you. Question, and our patients with optic neuritis ask that a lot. Is there a period of time, what she asked is, with optic neuritis in particular, also in Devix or neuromyelitis optica, is there a period after which if you haven't regained more vision or it's stabilized that you can say that things are going to remain the same? I used to say, well, they used to say 6 months for the central nervous system, any injury, and then they extended it to a year. And, in general, what I tell my patients is about a year, but I've had patients who have surprised me, both had MS and not NMO per se, but had bilateral optic neuropathies, not acute optic neuritis, just smoldering, sort of getting worse or staying the same, and both were in very visually oriented professions, and we were quite concerned, and returned after a while, and we're starting to improve. And I don't know if the other experts, like Dr. Bowen and Greenberg and Kerr, have seen this occur with other systems or with vision per se, but I'm humbled by how often there are outliers. But what we tell people is generally a year. Do you guys agree with that? Jim Bowen's shaking his head, yes. About a year is a rough guide. But I remember when that was 6 months, so maybe someday we'll be saying it's longer. And our dream is that we can intervene with a drug that will protect these nerve cells even earlier. And we say the earlier the better, but we think that that will be around the corner. And we're just pleased to have a model to be able to show that, to be able to look at it. Thank you.